Well, it's quite clear that whatever we're doing, even though it all looks great on paper, is not moving our organization in the right direction. We cannot wait even one more quarter for the numbers to improve before we make some hard decisions.
We've got to find a way to streamline our processes and to communicate with each other more effectively.
We've got some ideas of what we can do differently to help the hospital readmission issue.
Thanks, Jean. I know you and others have really been thinking about how to tackle this issue, and you've explored a lot of good ideas out there. But I think this situation, especially with new incentives to manage care for this population, is challenging us to look at this problem from a new angle.
We can't be the only ones facing this issue.
We're not. I'm not aware of anyone else who has the answer to this either. But there are experts out there who could help us navigate this if we are willing now to invest in this turnaround.
This seems like a huge undertaking. I feel like where we're headed now is uncharted territory.
There seems to be a consensus that this needs rapid and focused attention and that we need outside help. I'm also hearing two key streams of work: a focus on prevention and care improvement for the at-risk stroke population, and revisiting SDHN's broader strategy for using consultants. I would like the consultants to help us weigh our options. Now, as I see it, we have these four options. One, we could enter into total cost of care arrangements where we're at risk for all costs for the enrolled plan members. Chuck, I know Bluegrass Blue Cross is in favor of this option. Two, we could work in some sort of shared savings agreement where we'd share in the upside if targeted quality and cost outcomes for enrollees are achieved. We'd have some downside risk with this option, however. Three, we agreed to bundle payment arrangements where we'd be paid a defined amount for all of the care delivered to specific patients with certain medical conditions within a given time frame, like those with stroke. And four, we could stay with traditional fee-for-service arrangements in which the hospital where the stroke patient is initially hospitalized receives a DRG-type payment. Going with any of these will have significant implications. We need our consulting team to bring in both clinical and financial perspectives, which is what the triple aim is all about anyway. I could create a more specific charge for the consulting team if I can get a motion made and approved that STHN should bring in outside experts with those two themes in mind. Would anyone like to make a motion to that effect?
Wow, this was a real eye-opener. I just think the average person has no idea of the complexities these systems go through to provide good care, especially if we're talking the triple aim of trying to improve population health, improve patient quality while reducing expenses. The professionals are great. They want to be helpful, but it's just not enough. And quite frankly, I don't know if it's ever going to change. It sounds like they're trying to do everything possible to keep people healthy, but it's just not working.